Hi there, everyone. Welcome to our next session. My name is Marc Hurlbert. I'm the Chief Science Officer of the Melanoma Research Alliance. Very nice to be with you all today. Hope you're enjoying the sessions. And I'm thrilled to have some outstanding panelists with me. For the next hour, we're going to discuss doubling down on rare melanomas. And we'll dive deep on what's going on with some rare melanoma subtypes. What do we know about how they're diagnosed? How they're different than cutaneous melanoma, and what are looking like some treatment options coming down the pipeline. So before we dive in, why don't we just have each panelist introduce themselves. Again, I'll start with myself. For those of you just joining, I'm Marc Hurlbert, Chief Science Officer of the Melanoma Research Alliance. I'm thrilled to have been working with MRA the last 2.5 years. Why don't I introduce Trena Brown? You want to introduce yourself?
Hi, I'm Trena Brown, and I am a survivor of metastatic melanoma. And my introduction to this group was several years ago. They've really helped me to come to terms with what my rare melanoma is and how I can help people in my advocacy as I go forward.
Great, thanks for joining us, Trena. Dr. Richard Carvajal, you want to introduce yourself and tell them a little bit about your background?
Yeah, thank you, Mark. My name is Rich Carvajal. I'm a medical oncologist here at Columbia University Medical Center. I oversee the experimental therapeutics and the melanoma program here. And, I'd just like to thank the MRA for putting this together. I think, the MRA has been such a wonderful supporter of this field, and, the advances we've made in melanoma has been really, really tremendous. It's been primarily in cutaneous disease, and so there's a lot of work to do for the rare melanomas. And again, thank you for putting this on.
Thanks so much. And Dr. Alex Shustari, would you like to introduce yourself?
Yeah, hi everybody. I'm excited to be here and echo Rich's thoughts. I, like Rich, am a medical oncologist. I focus in melanoma. I'm the clinical director also at Memorial Sloan Kettering Cancer Center, so also in New York.
Great. Well, thank you to all the panelists. So before we dive in, for all the audience, you might ask, what are rare melanomas? We've already used a few terms you may or may not have heard of: cutaneous melanoma. So if I could just have the first figure 1, we thought we'd just use 2 schematics to walk you through a little bit of what are rare melanomas. And so if figure 1 is being displayed, what you'll see here, it's a stick figure. What you'll see in the black font are describing what we call cutaneous melanoma. In the United States, there's about 100,000 new diagnoses of melanoma each year. About 20% of those show up on the face, head, or neck. About a little more than 20% show up on people's arms and shoulders. A little less than 20% on hips and legs. And about 30% of cutaneous melanomas are on the body, the chest, body, back, and trunk of the body. So that's cutaneous melanoma. It's about 90,000 of the 100,000 cases in the US each year. And then rare melanoma subtypes are shown on the figure in red font. And so I'll start at the top of the body, but there's a rare subtype that occurs in the eye and the melanocytes in the eye called uveal or ocular melanoma. It's about 5% of the cases each year, so roughly 5,000 cases diagnosed in the US each year. Next is mucosal melanoma, and that you can think of as the moist mucosal tissues of your body. So when you think of mucus or mucous membranes, you probably think of your nose or sinus cavity. But all the moist tissues of your body, from your nose and mouth all the way down to the other end. It could include the sinus cavity, the mouth and oral cavity, the gastrointestinal tract, the anal genital region, the anus, the vagina, the penis. But so essentially, the mucous membranes of your body have melanocytes and could develop a melanoma. And then lastly is acral lentiginous, or just in short, we call it acral melanoma. And that occurs on the palms of the hand, the soles of the feet, and under the fingernail beds, under the fingernails or toenails. And so those are the main rare subtypes, uveal, mucosal, and acral, that we'll dive into today. And then there are other rare types not depicted here. So another rare type is melanoma that shows up in pediatric or adolescent populations. There's only a few cases of those each year in the US. Similarly, there's a rare type that shows up in the central nervous system. It's called primary melanoma of the CNS. So there are other rare types, but these were the main ones we're going to talk about today. On the second figure, if you can go to that one, this is just to show you a little bit. Scientists in really the last recent year or two have begun to unravel how these rare subtypes are similar to and different from cutaneous melanoma. So on this slide, you can see these are pie charts. You can see on the upper left corner, cutaneous melanoma is driven primarily, the most common is driven by BRAF mutations. That's in the blue part of the pie. About 50% of cutaneous melanomas are BRAF mutant. About 25% have mutations in what's called a gene called NRAS. Fewer have mutations in genes called NF1, and then there are other types you can see in yellow. And you don't need to know all these genes. I don't mean to give you too much of a deep scientific lecture, but you can see that the pie charts vary for cutaneous versus mucosal and acral, so and for uveal. So for example, there's much fewer cases of BRAF mutant melanoma in acral and mucosal, and almost non-existent in uveal. But yet that's the most common in cutaneous melanoma. So that's just a brief overview. We can take the slides down now and just go to our panel. But we wanted to start so that we're all on the same page and what are we discussing when we talk about rare melanoma subtypes. So with that, why don't we start? Trina, I'm going to kick the first question to you. But you shared a little bit in your introduction, but why don't you share a little bit about your story and how you got involved with MRA and melanoma advocacy in general?
Yes, well, my journey with melanoma started really in the 80s when I had marks under my big right toe. And I went to a dermatologist. The dermatologist told me, don't worry about it. You know, it'll probably get darker as you get older. Don't worry about it. It's nothing. So I didn't worry about it until 2013, when the darkness had emerged on the side of my toe and I thought I had a blister. Went to another dermatologist, and because of the size of the blister, I insisted that it be biopsied. And sure enough, it came back as suspicious, and he told me to see a plastic surgeon. The plastic surgeon excised it, and yes, it was acral melanoma. Subsequently, after many tests, I had my big toe amputated, and since I didn't know much about melanoma or cancer at the time, you know, I thought if my big toe was amputated that I was good. You know, like took 68 years for it to get there. You know, it wasn't going to happen again. But sure enough, in 2.5 years, it had metastasized to my lungs, even though I had a test on my sentinel node and the lymph node showed negativity. So with the metastases to my lungs, I started treatment. And that's where MRA actually came in. I went to a patient forum on the first.
Hey, everybody. As you can see, we're having a few technical difficulties with a live panel. So we are going to restart momentarily. Just give us a couple of seconds to check everything and get it back up and running. Thanks again for your patience.
Welcome back, everyone. Apologies for the technical difficulties. And thank you so much, Trina, for sharing your story. I think we'll come back to you and hear a little bit more. I think that the first thing I heard, even with your first diagnosis, Trina, was that was quite a journey to even get to what was going on with your toe and these strange dark streaks you were seeing on your toe. So we'll come back to that. It did spur a question I wanted to pose to Dr. Carvajal and Dr. Shoustari. So, you know, I think that with these rare melanomas, acral, mucosal, uveal, you know, often, like you heard from Trina, I think it's very often that patients don't know that it could be something wrong. They have to be their own advocate. And so sort of two questions. One is for Dr. Carvajal and Shoustari. One is, you know, what is the typical patient journey for some of these rare melanomas? Do uveal patients, you know, see an ophthalmologist, What's the journey for these patients? And then second, we'll come back and talk about how they get to experts like you at Columbia and Memorial Sloan Kettering, especially during the era of COVID, and when should patients seek second opinions? So let's start with the first question, sort of the general journey for patients.
Yeah, I'm happy to start, Mark. You know, I mean, Trina's story is not an uncommon one, I think. And as a physician, you might, you might understand that, common things are common. And when we're talking about some of these rare melanomas, for instance, an anorectal mucosal melanoma, it's very rare, maybe 500 cases a year in the United States. I would say about 90% of the cases that I see are initially diagnosed as a hemorrhoid, right? Hemorrhoids are infinitely more common. And, in Trina's story, the sublingual melanomas, they're just less common. And so the things that will come to mind, I think, for many physicians is, oh, it's just trauma. You've got a little hematoma under there, or maybe it's a fungal infection, it'll go away. And so I think that awareness is really, really critical, not just for the patients, but also for the physicians. Common things are common, but you have to be sure that, there's not something just rare in there about, that we have to diagnose. Mark, the patient journey is really, really distinct, I would say, for each of these melanomas. So it's hard to say that the patient journey for an anorectal mucosal, I mean, it's definitely different than someone with a sinonasal mucosal or someone with an aqueal or someone with an ocular. And maybe I'll just go one by one. I don't know, Alex, I don't know, because I think we can both speak to this pretty well. And maybe I'll just go with the ocular story. These ocular melanomas are very rare, a couple thousand here in the United States. About 2/3 of those patients will present with visual symptoms. And that will bring an eye doctor. But that means about 1/3 of these are diagnosed incidentally, during their routine eye exam. And so the journey for those patients, once they see the eye doctor, thankfully, many of the ophthalmologists, optometrists are aware of this pretty rare diagnosis. And when they see something that's suspicious, they'll refer someone to with particular expertise in this disease, an ocular oncologist. And once they're in the hands of an ocular oncologist, that's really where the treatment begins. And the treatment may include radiation oncologists frequently to help with kind of the surveillance. Maybe Alex, I'll let you talk about the mucosal journey,
Yeah, so I think, for patients with melanomas that arise in the hairless internal surfaces, so, as you said, Mark, inside the mouth, the nose, the anus, the vagina more than the penile mucosa for reasons we don't fully understand. They're all different parts of the body, and as Rich said, they're never the most common thing. And so oftentimes it's going to take a while to get the true diagnosis. And there's this tremendous sort of, I think, patient guilt or anger or both about sort of how long it took them to finally get the answer. And so I think, we always have to acknowledge that. And by the time they get to a Dr. Carvajal or a Dr. Shoushtari, they've been through a lot of of hard work to get there. And I try my best. I think we all try our best to acknowledge that. And they start to get some answers from people that are a little bit more specialized. In the mucosal area, it's tough because each surgeon, it's not one set of surgeons that does, all of these mucosals. So for each surgeon, it's by far the least common type of thing that they see. So a head and neck surgeon is going to see more, tonsil squamous cell cancers, for example, from HPV or smoking or something like that. And of course, a colorectal surgeon is going to see colon cancer that is a glandular adenocarcinoma way more often than they're going to see a melanoma. And so for me, that gets to the second part of that question of, in COVID, it's harder to do everything. It's harder to navigate the system. It's harder to physically move around. It's harder to have patients and family members come with them. And I think it's still important to have at least one, physician who's really passionate and about your specific problem. And the moment you start to connect with someone who's passionate about the problem you have, you get more answers, you get a little bit more peace of mind. And we recognize, or at least, I recognize that I may not always be the physician you see. It may be logistically challenging, but I think, having someone at least connected to me or Rich or any of our other colleagues around the country who are passionate about these rare melanomas, I think at least having one consultation or having a physician talk to us and say, well, if you have questions, are you running things by them? Are you emailing them? At the very least during COVID, that kind of remote consultation, I think is still super important. I'm obviously biased because it's what I do for a living, and everyone here is biased because they're interested enough to listen in. But I think that message is still important, even in the era of COVID.
No, I think it's a great point, Dr. Shoushtari. I mean, clearly not everyone can travel to New York City, to Columbia, or to Memorial Sloan Kettering, or to other specialized centers in other parts of the country. So I think it's a very great point about getting a second opinion and or getting one of those experts at one of these top centers to be somehow affiliated with your care, even if they're not directly your doctor. Now, Trina, I wanted to go ahead. So I wanted to circle back to Trina. I think hopefully we're still on. Trina, so if you could just go a little bit, I know you shared your story. I think one of the important messages I heard is about being your own advocate, and sort of when did you get to your medical home that Dr. Shoushtari talked about, the doctor that you have a great relationship with that's cared for you the last few years?
I was just extremely lucky. I've been blessed throughout this whole journey because the doctors initially didn't pay much attention to what was going on with my toe. I mean, even when I went to the second dermatologist and we found out there was something wrong, with the cells, he just said, go see a plastic surgeon. So I should I continue?
Yes, I think so.
Okay. So I've felt until I got to my oncologist that I was pushing the whole way, just trying to find the right person, to tell me what was going on and what the prognosis was. I mean, I honestly was just lost, until I got to the oncologist. And then, of course, when I got the diagnosis of metastatic melanoma, I just thought I was going to die because I went to Dr. Google, and that was not a good idea. He promptly told me I had 6 months to live. The oncologist was very sympathetic, just as Alex was talking about. He became the person that I could lean on and ask questions to and text, and made me feel comfortable with my procedure, and helped me to mentally get through everything. But I also want to not minimize MRA's influence as well, because it's a community of people that help you, that you can question. I found someone who had a similar circumstance as me, and you don't feel alone. So I mean, mentally, I think getting through cancer is just as important as physically. But anyway, I spend a lot of time now, because I am Black, letting people know that Black people tend to have more acral melanoma, soles of the feet, palms of the hands, under, the tongue, under nails, and people are shocked about it, but they've been getting back to me and letting me know that, like, I have 2 friends that found squamous cells, and that, that's dangerous as well. So I feel like I want to remain an advocate for the rest of my life, to help everyone stay alive, and particularly me.
Well, we're all very glad Dr. Google was wrong, and glad that you're an advocate with us today. Were you going to weigh in, Rich, and say something?
I was just going to say something. Trina, you brought up the idea of kind of community and how you can help, how patients and family members can help each other. I think when I see individuals with these rare cancers, I think many of them do feel like they've got something that no one else has, that no one else has heard of, and they feel lost for a long period of time. And so, I also, thank the MRA for kind of building that patient community to give people to reach out to who are maybe, going through something similar, maybe get a little bit of advice. I think that's really, really important. And in parallel, I think we need to do that in the medical and scientific community as well, right? We have to increase the number of people who are interested in trying to, make improvements in these diseases.
Yeah, and even after treatment, one of the side effects of my treatment was that it attacked my thyroid and my adrenal glands. I lost my hair. I got vitiligo, which luckily I'm a woman and makeup can cover that. But, my oncologist asked me the other day if I would mind speaking to another Black person who, vitiligo shows up much more intensely on darker skin. If I would be willing to talk with them. And of course I am. I want to be able to help them to skip through to, the right makeup and how to cover it and how to keep it on, and, just to help with the after effects. Even the rashes and, everything else that you go through, but it's all worth it. It's all worth it. I'm alive, so got to keep your eye on the prize.
Absolutely. So I was going to circle gears a little bit. So we had a diagnosis. Trina shared her story. Thanks, Dr. Shoustari and Carvajal, for sharing what uveal and mucosal patients might look like. But now that we have a tumor, it's been diagnosed, surgically removed, perhaps. Now they show up in your office as an oncologist. And I wanted to get to those pie charts that we showed with BRAF mutations and similar mutations. And just curious, and maybe we have to go through each of the rare subtypes on its own, but is testing the tumor for these mutations and biomarkers common at both of your institutions? I imagine yes, but is it common out there across the U.S.? What is the status of tumor mutation testing? What should MRA be doing to educate patients on this? And maybe we could have a conversation. Do we want to start with uveal again, Dr. Carvajal?
Yeah, so for uveal, a little bit distinct than other the melanoma subtypes, I guess, in that it's mutationally, I guess. If we're just talking about the DNA mutations, it's a relatively bland tumor, which means to say is if you remember that pie chart that you showed up, most of it is just this GNAQ and GNA11 mutation. Now, because of that, some may argue that for uveal, we don't have to do this kind of broad-based next-generation sequencing panel. I would argue that there are some molecular features that we can find on those panels that may be helpful. And for that reason, I do tend to do next-gen sequencing, which again is looking at the mutations. One of the things that we look for is a very small percentage of these patients have, as opposed to the majority that have few mutations, a few of them have a lot of mutations. And for those folks, they actually are ones who may meaningfully benefit from immunotherapy. And so in that case, that would change the way I manage their care. Now, and that's something that we do for patients with metastatic disease. I would kind of move up a stage earlier. For these patients who are initially diagnosed with a tumor in the eye, there are various assays that we can do that can help us estimate the risk how high is the risk that the cancer is going to come back? And to do that, the ocular oncologist would need to do a biopsy of the tumor at the time of primary treatment. When they do the radiation plaque, they can take out some cells and they can look at the structure of the chromosomes of the tumor. And they can say, well, if it only has one copy of chromosome 3, that makes us a little bit more worried. Or they can do another test that looks at whether genes are highly expressed or expressed less highly, and certain patterns would suggest that they're at higher risk or lower risk. And so for uveal specifically, I think that's something that patients should speak to their ocular oncologist about, whether it's something they should consider, what are the risks of that procedure and so forth.
Great. Now, Dr. Shustari, do you want to comment on acral and then mucosal?
Yeah, I think for acral and mucosal melanoma, I actually can't see the pie charts that you have up. I think it's just the view that I have, and they told us not to change the view. So, but luckily, I think I know what you showed. Just showing that there's a lot more sort of heterogeneity in acral and mucosal, whereas in skin melanomas, it's the uptake of checking for BRAF, particularly BRAF V600, I think is pretty darn high. And I would argue at a minimum that needs to be done for almost every melanoma, except maybe uveal melanomas. You could argue you don't have to check for that. So I think that uptake is pretty good. Dr. Carvajal and others, a few years ago showed that KIT mutations can be relevant and can be effectively targeted with KIT inhibitors in a slice of those patients. So somewhere in the range of 20% of people have some sort of KIT mutation. And back in 2011, when those data were published, we didn't really know a lot about even just the KIT inhibitors. We thought, hey, if we see it amplified and if we see it on immunohistochemistry, that means we should try to block it with imatinib or whatever. And unfortunately, that didn't turn out to be true. It turns out that certain specific mutations are much more sensitive. And so the location in the gene of the mutation matters. And these are things we learned over time. These are things we learned through trials, but also just run-of-the-mill clinical practice and people gaining that experience. And so now I think we're getting a little bit better at searching for sort of meaningful slices of the pie that we can treat effectively. And so why do I say that, I think almost all acral and mucosals, should undergo some broader molecular testing, not just BRAF and not just KIT. It's because I think, for people with, I'm talking mostly unresectable stage 3 or advanced, stage 4 disease, you're going to use PD-1 based therapy. That's the standard of care for both acral and mucosal melanomas. But there's enough people for whom that drug family just doesn't work. And I would argue, that in parallel, once you decide to start immunotherapy, you need to be looking for those other meaningful slices of the pie. And so we and many others have clinical trials for, NRAS mutations, for example, with novel targeted approaches there. We've even done some, kind of creative single patient use or off-label use of targeted therapies. It turns out that as we've done broader molecular testing at centers like MSKCC, Columbia, as people have sent it off for foundation testing or whatever, name your company of choice, we find that it's not just, okay, melanoma is this and breast cancer is this, these genes. You can actually find that certain genes define a subset of tumors regardless of where the tumor started from. So instead of saying, I have a melanoma and what mutation does it have, you can say, I need to look for an NTRK fusion. It's 1 out of 100 cancers, and there's almost no cancer subtype where it hasn't been found, at a very low level. And there's this, pretty dramatic improvement in outcomes when you use, drugs like larotrectinib or entrectinib for TRK fusions, but it's only 1 in 100. We published even a case of a HER2 amplification, which is sort of, most well known in breast cancer, where it's about 1 in 6 women overall, and certain subsets like women of color is much higher. And you can say, well, it looks like about 3% of mucosal and acral melanomas are actually HER2 amplified. And so, that opens up clinical trials or off-label sort of compassionate use indications where we're not just guessing. We are sort of learning from across oncology, our experience in saying, okay, this has a better than average chance of working. I'm not just trying something, where I have no track record at all. So I'm a fairly passionate, Rich knows this, it's a big sort of area of focus for me. I'm a big passionate advocate for a judicious, smart, proactive use of a broad genomic panel. And when we look just in skin melanomas, I know that's not the focus of today, but even in skin melanomas where we know that half of it is BRAF V600, we actually quantified like how often at Sloan Kettering it seemed to help us, help the patient, knowing a non-BRAF result in the real world. And we found that it took, for people that PD-1 didn't work for in skin melanomas, it took about 20 people to sequence to find one person where we gave them at least 6 months of benefit on a drug, and for some of them actually several years, and dare I say a happy ending for those patients. And so that 1 in 20 or so patients, they love it. It really changed their life. And I think that was in skin melanomas, but it easily applies, I think, to acral and mucosal melanomas as well.
No, I think that's great. Absolutely. It's exciting how quickly the science has evolved. You cited some work from 2011, 2015, how quickly some things have evolved. I did want to pause and note to the audience that you can ask us questions. And so if you want to type questions into the platform for the audience members. And we do have one question I'd like to pose to maybe to Dr. Shoustari. Have you heard of or have you had an experience with an acral melanoma that presented just as a fissure on the heel that ulcerated, but later turned out was an acral melanoma? I don't know how common that is. And again, maybe that's more of a dermatologist would see that, but I don't know if sort of a fissure or a wound on the foot later was diagnosed as acral, Alex. Dr. Shoustari.
Yeah. So I have heard that story even in my own clinic. Of course, by the time they get to me, as we said, they've made a circuitous journey, and I'm privileged to be so hyper-focused, like Dr. Carvajal is, to always sound like really smart, like the smartest person that they've ever met, because everyone else really tried to, figure it out for us. I think a fissure, like what's becoming increasingly clear is that acral melanomas are of course they're rare. When they arise, they do tend to arise in more inflamed or pressure point areas. Talking about the non-subunguals, I don't know as much about the micro, architecture of like the nail bed. But in terms of, where it arises on the feet, it is typically on the heels, the outer edges. And so unfortunately, like a wound that doesn't heal, or I'm sure Rich would agree, we hear a lot about it started with a trauma and never healed. And we used to think, oh, that's just a coincidence. You hit yourself, so now you started staring at where you hit yourself, and then you noticed it. But I think as we learn more, we're going to realize why sometimes it can actually start with a trauma. I would argue, I have no proof for that, but that's my strong hunch, that for some people that healing process actually feeds a rogue cell, and so it can be a really difficult thing to determine? When is that crack? I mean, we all have things on our feet and long days, and women have uncomfortable shoes and this and that, and it's hard to tell, but I have heard that before.
Absolutely. So we have about 20 minutes left, and so maybe we'll shift gears and talk a little bit about treatments for 10 minutes, and then we'll talk about future directions and where research is headed. So for treatments, Trina, I don't know if you want to talk more at all about your metastatic diagnosis and what your treatments were. You described some of the side effects.
Yeah, sure. I was put immediately on a combination of Opdivo and Yervoy, Ipi, and Nivi. I went 4 cycles with that, and then for the remainder of 2 years, I was on Opdivo alone, the Nivi alone. And when I got, the worst part of it was the beginning, just all kinds of side effects. The worst was actually a rash on my back that nothing seemed to calm. I wasn't getting sleep, but I also was determined that I was not going to put anything else in my body. I wanted this, to work. So, and it did work. After my first CAT scan, after the 4 cycles, showed that my tumors in my lungs had shrunk considerably, and I just had scar tissue left with some of them. So I was happy about that, and it also gave me some impetus to, to keep going. So it went 2 years with that, and as I said, the immunotherapy attacked my thyroid and my adrenal gland, but who cares? I'll be on steroids and thyroid medicine the rest of my life, but that's an easy thing to do when faced with the alternative. So that was basically it. Just I cannot describe how horrible the rash was. It was no sleep for like 3 days in a row at times until you just fell asleep. But it worked.
Glad it worked, and sorry for the permanent side effects, but glad overall it's a good journey for you. So, Dr. Carvajal, Dr. Shoustari, so these immunotherapies have clearly made a difference in across all melanoma types. Do you want to comment? I think it's exciting that they work in acral and in some mucosal. Do you want to comment on sort of where we're at with immunotherapies and the rare subtypes?
Yeah, I mean, Trina, it's I'm so glad at this outcome. It's really fantastic, and I think the toxicities with this combination checkpoint blockade, they can certainly be quite bad, no doubt. But why do we do that? In cutaneous disease, we're seeing major response rates, major tumor shrinkage in more than half of the patients that we treat, and now we're talking about curing, maybe up to 50% of patients with metastatic disease. And that is, it's not as high as any of us want it to be, but, compared to where we were 15 years ago, 10 years ago, right? This is a major, major advance. And so, as I think everyone in the audience knows, I mean, all these rare melanomas are extremely understudied. And so what we've done for years is just translate what we've done in cutaneous disease and just hope it works in the rare melanoma subtypes. And I think what we've seen, for instance, for acral melanoma is that, many of the series that where we've looked at, does checkpoint blockade work? Many of them have shown that it can work with response rates, similar to what we see with non-acral cutaneous disease. There are some trials or series that don't show that, but that's one of the struggles with the rare cancer research. We're looking at many small series and trying to make sense of that. Now, on the other end of the rare melanoma spectrum, we've got uveal melanoma, where even with this aggressive combination checkpoint blockade, the best response rates that we're seeing are in kind of the mid to high teens, right? And survivals, we're still talking, not where we want them to be. So you compare a 50-60% response rate to like a 15% response rate. Median progression-free survival with uveal, that is, how long can we keep things from growing? It's an order of months, and it's And it just highlights, the difference biologically and clinically of cutaneous melanoma, acral melanoma, uveal melanoma. I think Dr. Shoushtari has done a ton of work looking at checkpoint blockade in mucosal. So maybe I'll turn it over to you, Alex.
Yeah, no, thanks, Rich. I agree. It's been, let's just take what works in cutaneous and hope that it works. And it's interesting to me, and what I try to, the way we try to advocate. I know Rich does this better than I do to get funding for our ideas, is to say, why should Joe Grant, giver outside of MRA, I'm talking about, the MRA is all in, but Joe Q checkbook is like, why should I care about this corner of oncology when there's still people dying of pancreatic cancer and colon cancer at higher rates? And for me, what is so interesting is that we can say, listen, melanoma has it at every end of the spectrum of what oncology is struggling with. We've got survivorship issues with checkpoint in cutaneous. We've got successful targeted therapy in cutaneous. On the other end of the spectrum, we've got uveal melanoma, where it's a low mutational burden, and we've successfully now shown actually a novel class of immunotherapies that both Rich and I have, and many others have contributed patients for, a drug called tebentafusp. And then we've got acral and mucosal, where the mutation rates that drive the response in cutaneous aren't there. They're just not quite as highly mutated. And yet the response rates are better than you would expect from uveal. And so we kind of have this like Goldilocks phenomenon where you can try to sort of advocate for studying and developing drugs from these drug companies and from these grant agencies based on sort of every end of the immuno-oncology spectrum. And so that to me is the way to drive more interest and development to get past what we had been doing, which is just copying everything from cutaneous. We're starting to get away from that, and maybe Rich wants to talk about tebentafusp, for example, in uveal, which is, I would argue, a paradigm shifting agent.
Yeah, I think finally we're starting to see clinical trials developed specifically for these rare melanoma subtypes. And that's absolutely critical. Now, there are challenges with that, of course, right? The expense, the cost of trying to develop drugs for patients who are scattered all throughout the country and with very low density, right? How do you treat patients with mucosal melanoma on a trial when there are 2,000 patients diagnosed total, a year in the U.S.? How do you get them to the centers where these trials are being done so you can accrue at a reasonable rate and answer the question you need to answer? It's hard. But I think we have to be creative about how these trials are designed, how we can minimize the number of patients needed to answer the question, as quickly as possible. How can we have the clinical trials open in as many centers as possible, geographically dispersed to give access to people as much as possible? It's absolutely critical. And so Alex brought up, one of the drugs that's been developed for uveal melanoma is this drug called tebentafusp, which is a novel sort of immunotherapy that really binds very tightly to the uveal melanoma cells, and then kind of brings in the immune cells that are in that microenvironment, and just brings the cancer cell and immune cell in proximity so that the immune cell is able to kill the tumor cell. Alex, myself, others, we've participated and worked on clinical trials specifically for uveal melanoma, doing a phase 1 and 2 trial, and just recently announced at AACR were the results of a nearly 380 patient international uveal melanoma trial where patients were randomized to either this new drug, which tebentafusp or tebi, versus kind of the standard of care therapy arm. And this study showed for the first time ever that we have a drug that reduces the risk of dying from melanoma, from uveal melanoma, by 49%.
Mhm.
We've never found a drug that meaningfully improves survival like this. And I think this, study showed this development plan showed a few things. One, by developing therapies that are really specifically designed for these rare cancers, right, we can find drugs that work. And two, it is possible, although it needs many centers and a global effort, it is possible to do these trials that prove that a therapy can be effective.
I think that's a great segue in the last few minutes here. Let's talk about future directions in research on rare melanomas. There was one question from the audience: what is MRA doing to push forward research on these subtypes? And I'll say, we've funded about just under $15 million in our 12-year history to advance research on rare melanoma subtypes, defining how acral, mucosal, and uveal are similar to or different from cutaneous, identifying new potential druggable targets. You heard earlier in our discussion around KIT as a target in mucosal and acral. Now there's a trial specifically looking at KIT inhibitors in combinations, and recruiting acral and mucosal patients. I think a point Dr. Carvajal just raised is, how are we going to do studies when there's so few patients across the US or even across the world? How are we going to do studies? And to that end, I think there's a new endeavor. MRA is launching a rare melanoma registry focused on patients with acral and mucosal melanoma. Anyone diagnosed with acral, mucosal, or their family members or caregivers can join the registry. We'll be launching later this summer. And this registry will help us collect information on a large scale. Many of the studies published with these rare subtypes often look at 20 or 30 patients, and we're hoping to study, hundreds of patients with each subtype and understand their journey, what treatments they've had, and how their quality of life is changing over time. And then the other thing, when you have this large cohort of patients in a registry, is to be able to educate them about when there are clinical trials. And let's hope they don't have a relapse or a recurrence of their disease, but if they do, what are the latest trial options for them? So I think this idea of patient registries is critical for building a community of these rare diseases, rare cancers. I don't know, Rich, do you want to talk about your uveal registry? I know you have one at Columbia, as well as working with other nonprofits.
Yeah, and so on the uveal front, we've got two parallel registries, and Dr. Shoushtari is working on this effort with us as well. On one end, we've got a global consortium of academic centers in the US, Canada. We have Princess Margaret on board, Germany, UK, and Australia, where we're going to be pooling the data of all the patients that we're treating worldwide, right, at our centers, to try to see, can we better understand, what the clinical implications of particular genetic findings, for instance, are. How, what is the impact of some of the surveillance or scan strategies that we're pursuing are. In parallel to this academic effort, we're working with another organization called the Melanoma Research Foundation, CURE-OM group, who's launching, much like the MRA rare registry, they're launching on Monday, actually, a registry called Vision, which is a patient-powered registry, again, to help chart the patient journey, help with education, help build community, and help drive accrual to some of these really critical clinical trials.
That's great. And Trena, maybe I'll turn to you. You've been helping the MRA advise us and guide us as part of a group of 12 patient advisors, helping us design our registry that will launch later this summer. What would your advice or guidance be to patients that are listening today about why they should get involved?
Well, I think it's really important to have support, and to understand that you're not alone. And the only way to do that is to talk to people, which, at first you're probably hesitant to do. I wasn't. But, I think it's very helpful to talk to people who have been in similar situations or maybe unsimilar situations, just to register your thoughts. It's been interesting working with the group because I've learned so much even about acral and mucosal and uveal melanoma, just talking to the patient advocates, that have been working with us. And there's so much out there. There's so many different approaches that people have been talking about, but the registering with the rare melanoma registry, I think, will help to bring groups together to better understand their own situations, as well as to help MRA look into other areas deeper, that haven't been uncovered yet. It's really been a great experience. Actually, it's really been a great experience.
Well, thank you. I think knowledge is power, and that's what we'll learn a lot of knowledge about acral and mucosal through the rare registry. Dr. Shustari, we have a few minutes left. Do you want to comment on some of the exciting new trials and treatments that are in the pipeline? I've seen such an exciting time in melanoma with LAG3 and new IL-2 generation and things like that.
Yeah. It's, I'm going to try to give a little bit of a flavor and not be too biased to maybe whatever I'm doing, which I always think is the coolest thing ever. So I think you mentioned LAG3. I think that's here to stay. I think LAG3 is a new checkpoint, kind of in the family of PD-1 and CTLA-4 that nivolumab, pembrolizumab, and ipilimumab block, respectively. So all we have so far is a press release. I think ASCO, next month is going to be an important meeting where we find out that this relatlimab drug that blocks LAG3 improved, control of, again, cutaneous melanoma as a first treatment compared to just nivolumab alone. And so to us, that's usually a signal that, it's something that's biologically relevant. And then we, again, are going to, look for, LAG3 to be playing a role in other rarer subtypes. There's a trial, for example, of LAG3 and PD-1 inhibition. I think University of Miami is leading that based on specific analysis of uveal metastases. They are optimistic that it may play a role there. Modified IL-2 approaches are I think getting closer to pivotal trials. They are in pivotal trials. They're getting closer to knowing whether they're going to work and pass that final hurdle. I know of at least one specific mucosal melanoma trial that's being planned with a modified IL-2 agent. Other approaches like, for example, taking out a tumor, and reconditioning those tumor infiltrating lymphocytes, or what we call adoptive TIL therapy. The company furthest along for that has a drug called lifoleucel that had some pretty exciting data, again, mostly in skin melanomas. And if that passes muster at some point, that whole adoptive TIL approach, there's no reason you couldn't try that for a metastatic mucosal or metastatic acral. So we're always hard at work. There's numerous other approaches, injectable, viral approaches, or TLR9, agonist approaches. There's inhibiting like other pathways that we think are quieting immune systems, like Wnt signaling and stuff. So there's all sorts of different ways. It's getting harder and harder to stay on top of all of the novel approaches, and it's a divide and conquer. I think different groups are taking slightly different approaches, and as long as we get patients, to support and trust us to enroll on a clinical trial, I think we are going to see progress continue.
Great. Well, I think we're just about out of time. So I want to thank all three of you for joining us today. It's been a great panel discussion. Trena Brown, thank you for all your advice and guidance over the last year. Dr. Shoustari, Dr. Carvajal, great to see you. and really appreciate your time. But it's an exciting time. I think we're making progress against rare melanomas, and the future is very bright. So thank you all.
Thanks for having me.
Thank you.